Okay. So for the seventh editions of Innovations of Oncology, I welcome you all for the day two. Yesterday we had the first day of the innovations with the talks on lung cancer, and it is my privilege to invite everyone for the seventh Innovations in Oncology second day. So I will request our organizing chairman, Dr. Pendakar, to set the event by having a 10-minute innovations in oncology speech and to set the event rolling. And then we'll have the masterclass by Dr. Advani sir for the second day. And then we have a talk by Dr. Kunal and also a panel discussion today. So over to Dr. Pendakar to have the start of the day.
Hello, good evening, everybody. And it's my honor and pleasure to be here. Dr. Advani sir is already there with us, so I would like to be as short as possible. For all my colleagues, I just wanted to, especially from the districts, I really wanted to bring two very, very important issues. What is changed in oncology in last 3 months is in few cancers which are most common. So the commonest cancer all of us are seeing are head and neck cancer. The second commonest we are seeing is lung. And the common most cancer which everybody is seeing irrespective is chronic myeloid leukemia. And the treatment of all three diseases have drastically changed in 3 months. So if we talk of chronic myeloid leukemia, generic dasatinib has become available and the cost of nilotinib has come down. So now the question is imatinib, dasatinib, nilotinib. And oncologists have slightly started shifting for first-line treatment from imatinib to other drugs. So the major issue remains when to shift or not to shift. So this is a very, very critical issue because all of us are already tuned how to treat chronic myeloid leukemia. All of us already know how to treat chronic myeloid leukemia. And because of this shift, we definitely do expect some problems in management of the patient because there may be old patients who may come to you and say, can I try the new drug? So my humble request, especially for my physicians from the districts, no switching unless prescribed by the oncologist, and ask the patients to go back to the original oncologist for resolving this issue. Because still the transition is really very fluidy. We still don't know when to transit, when not to transit. So please be very careful. But important, remember, the most important point here is the changes can only occur if you have a documentation of BCR, ABL quantitative report in the file, and probably not one, multiple. And I've seen patients in practically every district where this report, the original report is available, but the follow-up reports are not there in the file. The follow-up, the patients do not have the follow-up reports. So please, everybody, be more strict with following with BCR ABL quantitative 3 monthly, worst situation 6 monthly, because this would only allow transition. This would allow the usage of other drugs. This is about chronic myeloid leukemia. The change which has occurred in lung cancer is phenomenal. So now, non-small cell lung cancer, practically every group, immunotherapy has been approved as a first-line treatment, irrespective of any investigations. So our major problem is we have patients who do not have mutation reports with them. So if they do not have a mutation report with them, can we prescribe immunotherapy? Again, a very technically a very challenging question. So I request all the district physicians to refer the patient to the oncologist for resolving this issue, number one, and please request the patient to stick to one oncologist, whomsoever they want to follow. Because in between oncologists also there is an expected change of opinion because the philosophy of first line use of immunotherapy in especially like squamous cell carcinoma is getting established. In adenocarcinoma, with non-availability of mutation reports, it is again plus minus. But then These are very serious issues. The cost of drugs is very high. So probably the request patient to stick to one oncologist who can go to his tumor board and take a call and advise what should be done in this particular patient. Similarly, in small cell lung cancer, immunotherapy is emerging as a first line treatment. So that again, the treatment is changing very fast. Cost of drug is very high. So please, again, be very careful about lung management of lung cancer. As far as head and neck cancer is concerned, there are some indications that drugs like gefitinib are getting prescribed from practically every institution. And if I'm not wrong, there was a suggestion and there was somehow some kind of a recommendation that it can be used widely. So please keep following that recommendation on the usage of gefitinib in head and neck cancer, how to use and what to use it. I think these three major changes, because these are the three major patients we have. Another change which is happening in breast cancer is the number of patients receiving neoadjuvant chemotherapy is increasing. Number one, we are now, the trend earlier in the country was like, if it is 4-AC, 4-paclitaxel or 4-AC, 4-docetaxel, the earlier trend in the country was 4-AC surgery followed by remaining docetaxel. The original recommendation of NCCN, as we all know, was always complete neoadjuvant chemo before surgery. So in the country today, yes, the patients are, the institutions are moving towards this philosophy. So more and more patients are completing neoadjuvant chemotherapy before surgery. So that's a new trend. So now with this change, we should remember that we have to finish chemo before surgery. Take your tumor board into confidence, take your surgeon into confidence and decide. And in HER2 positive patients, the neoadjuvant chemotherapy is including more and more of pembrolizumab, trastuzumab plus pertuzumab, both drugs together. So when you are using both these drugs together, it is very important to analyze the reports of the surgery, the histopathology report, how much live tumor is remaining. And if there is a tumor remaining at the end of surgery, you may switch over to TDM1 in adjuvant therapy. So these are new guidelines. Lot of oncologists are likely to shift to this, maybe slowly, but they would ultimately shift to this. So please keep following breast cancer very, very closely. I think, Suman, that's all I would like to say. Thank you.
Thank you, sir. Thank you for for such a wonderful start. Now I would like to hand over the stage to Dr. DC Doval, sir. I think sir needs no introduction. Sir is the pioneer in medical oncology, and sir will chair the next session. Over to Dr. Doval, sir.
You all, and I think without wasting much of time, we'll start that session on next session. And this is the role of pathologists in the era of targeted therapies and immunotherapy. As you know, Dr. Bhandarkar was already making a note that targeted therapies and immunotherapy are becoming very, very important, especially in lung and head and neck cancers, and they're finding their place in other malignancies. So I would invite now the speaker to speak on the role of pathologists in the era of targeted therapies and immunotherapy.
Good evening, everybody. Thank you, sir, for allowing me to present my presentation today. Am I audible?
Yeah, you're
Yes,
audible.
sir.
All right. I'll just share my screen and presentation.
Sure, sir, please.
One second. Is my screen visible now?
The screen is not visible.
No, it's not
Screen
visible.
is not visible. Screen is not visible.
1 second, sir.
Can I share your presentation, sir?
One second, I'll just try to share it. Yeah, I think it should be visible now.
Yeah,
Yeah,
it is shared.
it is
Yeah, it is
visible.
coming.
So your screen is coming. Yeah.
Yeah, one second. Fine. So good evening, everybody. It's really nice to be presenting on this auspicious day of Dashera. I would first like to wish happy Dashera to everyone. So, starting with that, the topic of today's presentation is the role of pathologist in the era of targeted therapies and immunotherapy. So, just to briefly outline that we have shifted when we started with the treatment of cancer in general. We started with chemotherapy. Chemotherapy, essentially, as we all know, is something that kills all the rapidly dividing cells, including a lot of normal cells in the body. But then there was the search for finding out treatment options which would selectively kill the cancer cells without very less side effects on the normal cells in the body. So that led to discoveries of targeted therapies and immunotherapies. So to just outline the basics, what is a targeted therapy? So targeted therapy is something which inhibits tumor growth and progression by blocking the mutant protein and signaling pathway, which are essential for cell survival. So basically, there is if there is a receptor which is essential for cell growth and division, targeted therapy will tend to block that, and thus it will be selective for the cancer cell which will be harboring that mutation, but it will spare the normal cells. We have seen striking therapeutic responses historically in a lot of cancers, like chronic myeloid leukemia, where we know the BCR, ABL kinase domain, imatinib has been used. Lung cancers, where we are using EGFR, ALK, ROS1, and a lot of other targetable mutations. Colorectal cancers, KRAS, NRAS, BRAF, other GI malignancies, and melanomas, again, where the BRAF V600E mutation has been used extensively for targeted treatment. The issue with targeted treatment that we are seeing, is that there is emergence of drug-resistant clones. For example, the T790M mutation, which is usually seen when we start the patients on EGFR tyrosine kinase inhibitors, those who are EGFR mutated in lung cancers. So this is a common problem which is coming with almost all the targets. Having briefly described about the targeted therapy, I will now like to just outline what is immunotherapy. So we all know immunotherapy means strengthening the body's own immune system to fight diseases. And immuno-oncology is the use of immunotherapy to treat cancer. Now, the modern immunotherapy approaches focus on T cell responses and augmenting the cell-mediated immunity to cause tumor destruction, something which we call as immune checkpoint blockade. So basically, it is strengthening our own T cells to kill the tumor cells. The first effective FDA-approved immunotherapy was the interleukin 2 and interferon alpha for metastatic melanomas. The newer therapies, which included checkpoint blocking antibodies targeting cytotoxic T lymphocytes associated protein 4, that is CTLA4. This is the ipilimumab and tremelimumab, and the programmed cell death protein, that is PD1, mainly nivolumab and pembrolizumab, with its ligand, that is the PDL1, which has become the hot topic of discussion, thus targeting immune tolerance. So PD1 and PDL1 are the pathways through which tumor cells evade getting killed by the T cells. I will just briefly outline them a little more in detail in my coming slides. Novel examples of the use of immunotherapy have been durvalumab in melanoma, then non-small cell lung cancers, triple negative breast cancers. In NSCLC, we all know that pembrolizumab came as the companion diagnostic. And in triple negative breast cancer, we have atezolizumab, which is there for the SP142 clone for triple negative breast cancer. Now, the issue with immunotherapy is usually primary resistance or acquired resistance or an adaptive resistance, which could be primary or acquired or a mixed response to treatment. I thought I will just share one example of each. So a very commonly used target therapy is the tyrosine kinase inhibitors in EGFR mutated lung cancers, NSCLCs. So we all know EGFR is epidermal growth factor receptor, which has an extracellular ligand binding, and it also has an internal intracellular tyrosine kinase activity. So upon the binding of this ligand, there is autophosphorylation of tyrosine residues on the intracellular domain, which results in activation of multiple transduction cascades, and that causes the uncontrolled cellular proliferation, resistance to apoptosis, invasion, metastasis, and angiogenesis. So basically, we then use the tyrosine kinase inhibitors, which are the first generation, second generation, and third generation, like osimertinib. So this was the example of targeted therapy. Of immunotherapy would classically be the PD-1 and the PD-L1 immune checkpoints. So we all know that PD-1 is present on the T cells, while PD-L1 is present on the tumor cells. Now this PD-L1, when it binds to the PD-1, it causes inactivation of T cells, so that these T cells cannot kill the tumor cells, to put it simply. So that is where we are looking at something that blocks this pathway, and thereby it causes the T cell activation to kill the tumor cells. So from surgery to radiation therapy to chemotherapy to immunotherapy and targeted therapy. Immunotherapy is something that we know as the fourth pillar of treatment in oncology. Now, I thought I'll just like to take one more example of how we do the testing and what is the role of a pathologist. So the role of pathologist is very simple. We have to look for these targetable mutations. We do them through various platforms. It could be the PCR, it could be next generation sequencing, or it could be even immunohistochemistry, like we do in case of ALK1 in lung cancer, or PD-L1 IHC. We have the DACO and the Ventana clones. There are specific clones for specific monoclonal antibodies. So this is just another example of where we use testing for targeted treatment in colorectal cancer, the KRAS, NRAF, BRAF, and PIK3CA mutations, and that we use to analyze whether the patient will respond to anti-EGFR therapy or not. Some of the tests that we have for testing on extensive panels are the hereditary cancer panel, which tests about 49 genes, which could be these are actionable targetable mutations. And we have something in SRL like the lung cancer panel, where we do elaborate testing for genes which we can use to target in case of lung cancer. The basic genes being EGFR, ALK, and ROS1. This is just another example of where a pathologist comes to play a role. This is the PD-L1 testing. So there is something known as the CPS scoring and the TPS scoring. The TPS scoring is the is something that we use mainly for lung cancer, and the CPS scoring is what we use for other cancers. The combined positive score and the tumor progression score. So this is just an example of how we calculate TPS versus the CPS. In TPS, we take the proportion of only the PD-L1 positive tumor cells, whereas in CPS, we take the combination of tumor cells as well as the tumor infiltrating lymphocytes, macrophages, and the staining differs. While in tumor cells, we only take the membranous staining as positive, but in immune cells, we take the membranous as well as cytoplasmic staining as positive. This is an example of these are the tumor infiltrating lymphocytes that you can see, which is very commonly seen with the SP142 clone of Ventana, which we use very commonly for the triple negative breast cancers, where atezolizumab is used. And again, we see the T cell, tumor cell, and TIL interaction through the PD-1 and the PD-L1 ligand. Now, the binding of the MHC anti T cell receptor triggers the T cell signaling, and as we discussed earlier, that PD-L1 causes the inactivation of T cells. So what is the something that I would like to say, I would like to highlight for pathologists who are using these tests is the fact that we have to understand that the cutoffs of these scorings are different for different cancers. Like if we are using the SP142 for urothelial cancer, the cutoff is 5%, whereas for triple negative breast cancer, it is 1%. So we have to keep those things in mind. Also, many a times I see oncologists who do get irritated by something something that we don't realize from our end. That is that the cutoffs which are given for PDL1 positivity high and low in lung cancer are not the same for other cancers. For example, cutoff of 1% and less to call something negative, more than and greater than equal to 50 to call something high, is for lung cancer. If we cannot apply the same for, let's say, a bladder cancer. So if we get a 10% CPS in bladder, and if we call it PDL1 low, that can sometimes create a lot of issues for oncologists when they are facing the patient. So the best way forward is probably for us to just give the score and leave the interpretation of high and low to the referring oncologists. These are just some practical points I thought I will enumerate. So the era how we are going into in the way forward is combination of targeted therapies and immunotherapy. This is very extensively being studied in melanomas, where BRAF mutant melanomas are being given targeted treatment for short-term benefit along with immunotherapy for long-term benefit. Durvalumab and plus dabrafenib plus minus tramitinib are being evaluated. Bevacizumab and ipilimumab has already been tested. Other cancers which are being tested are the non-small cell lung cancer and renal cell carcinoma. So another very important practical point that I would like to highlight is analyzing the tumor response. Sometimes when we give immunotherapy, you can see the first one is good response, where you see a lot of lymphocytes. The second one is progression, where you see much more tumor cells and very few lymphocytes. But the third one, where you see tumor cells are also increasing and lymphocytes are also increasing. What is that? So that is something which is known as a pseudo progression. Basically, why this happens is that as the immunotherapy starts working, because of the inflammation, the tumor size increases. So sometimes on scans, we interpret as if the tumor is growing, but these are pseudo progression and the therapy is actually working. So I would just like to conclude by stating that the gist of the role of a pathologist in targeted treatment and immunotherapies are diagnosing the correct morphology and type of tumor. For example, whether it's adeno or squamous cell carcinoma in lung, the further molecular testing depends on that. Knowledge about various tests available to assess targetable mutation and immune checkpoints. For example, KRAS, NRAS, BRAF in CA colon, PDL1 positivity in a lot of tumors. Knowledge techniques available to assess these targetable mutations and immune checkpoints. For example, IHCs can be used for ALK1 and PDL1. The ideal technique and the ideal interpretation in the personalized medicine scenario. While multi-gene panels are better for analyzing situations like lung cancer, but we also have to keep the costing in mind in a country like India. And also for treatment response, like liquid biopsies for EGFR resistant, that is T790M mutations, and to analyze true progression versus pseudo progression, which I just highlighted. With this, I would just like to conclude by saying that happy Dashera to everybody. May the good surround us all and brighten our paths. So the good and the bad stays within us, and that is what we intend to do with targeted treatment and immunotherapy. We want to strengthen the good so that it kills the bad, that is the cancer. Thank you so much.
Thank you, Dr. Kunal. And I think the House has opened the question. Very, very important thing that should be remembered is that communicating with pathologists is very, very important. If you are not communicating well with the pathologist, sometimes it can be dangerous. And I think it's in the time of multimodal treatment, I think we all should be communicating well with each other so that we can give the best to our patient. Any questions, Mr. House?
Yeah, can I ask you one question?
Sure, sir.
Why are we calculating the tumor cells and the normal cells as well as the lymphocytes? It makes it complicated. I do not know how it makes the real sort of answer ultimately.
Sir, I really thank you for the question. You have highlighted something which is confusing for a lot of people. What I have been able to understand is the fact that in case of lung, especially, the lymphocytes are very few. That's why they calculate the TPS scoring. But in most other tumors, it is the infiltrating lymphocytes which are in plenty. That's why we go for the CPS scoring. And when we talk of specific clones like SP142 triple negative breast cancer. In that, the SP142 it doesn't stain the tumor cells that great. So that is where we are calculating the immune cells rather than the tumor cells. So I hope this to some extent rationalizes your question.
Yeah, thank you.
There's another question from Dr. Amish Vora, please.
Sure, sir.
Dr. Amish, please unmute and ask your question.
It is
So
in the chat box.
Kunal, so
Good evening, sir.
my question is, if PD-L1 by say one platform is more than 50%, say assuming 80%, then will changing a platform which is FDA approved, or will TPS to CPS make any clinically meaningful difference?
Sir, I believe, I genuinely believe in the fact that platforms and the clone that we use and the associated antibodies should be very strictly adhered to. This cross functioning can sometimes create a lot of disturbance. As I just
No,
said,
I agree
yeah.
on that point. But assuming that an institute has done on a DACO platform, and
Right.
if TPS is 80%,
Right.
will it changing to Ventana or any other platform or SP142, will it make a difference in terms of percentage difference is maybe 15%, 20%, but clinically it will not be meaningful. My question is extension to what Advani sir has also asked the question.
Right. So, sir, again, that's what there are very particular scenarios where it makes a difference. Otherwise, it doesn't. Like if you're talking about a lung cancer and you have done, whether it is a DACO or a Ventana clone, but the cutoffs have been met and it's a very high percentage, then it doesn't really make too much of a difference. You can probably go ahead with the immunotherapy that you intend to use. But again, if you are talking about triple negative breast cancer, then we have to be very, very selective. Thank you.
If there are no more questions, I will hand it over to the organizers for the procedure.
Thank you, Doval sir. Thank you for your esteemed presence, and thank you, Kunal, for this wonderful talk.
Thank you,
Now I will like to invite Dr. Rakesh Gupta sir, who is the chairman of Sarvodaya Healthcare, to give his welcome address to this distinguished audience. And can I invite Dr. Rakesh Gupta sir?
Yeah, sure. Am I audible, sir?
Yes, you are audible, sir.
Yeah. Good evening, friends. It is my proud privilege to welcome each one of you, all the delegates, all the faculties, and especially Dr. S.H. Advani, who is a luminary in the field of oncology. And today, Dr. Sumathis and Dr. Pandarkar's team has taken this initiative of holding this onco conference. I wish the conference all the best, and I once again welcome all the delegates, all the faculty, and I'm very, very thankful to each one of you to participate in this particular conference, both as delegates as well as faculty, and guiding us through this particular conference. And I wish this conference a huge success, and I wish that we keep on holding such scientific deliberations time and again. Thank you. Sumat, you can take on.
Thank you, sir. And I invite Dr. Rajesh Vasis, sir, to chair the next session and invite the faculty for the next session. Over to Dr. Rajesh Vasis, sir. And it's a pleasure to have him every time.
Good evening, everybody. And thanks, Dr. Sumant and Dr. Parnadkar, to organizing this wonderful conference. Innovation in oncology that is needed at the time. Now, I invite Dr. S.H. Advani. Dr. Advani is no need. Every oncologist known him. He may be surgical, radiation or medical oncologist. He know him. Advani is very known and very respected person to everybody. Now, his topic is master classes in head and neck oncology, from chemotherapy to immunotherapy. How we have evolved. Now let us to Dr. Advani. Good evening, sir.
Good evening.
Good.
First of all,
Again
happy,
here.
happy
Very
Dasara.
good to hear you. Happy Dasara to all of you.
Thank you. Happy Dasara to everybody, and it's my proud privilege to be here to discuss some of the changes that we have seen over a period of 40 years in the management of the head and neck cancer. Head and neck cancer, all of us, next slide please, we have seen all over. Everywhere we have seen the head and neck cancer in India, but however, its incidence remains low in the European countries. And here you can see that the incidence of the lip and the oral cavity is so small. However, what you can see in this, that the head and neck cancer incidence may be small in Europe, but the mortality is quite high, and it remains so even today, particularly with the advanced stage disease. In spite of all the progress that we have done in last so many decades, the head and neck cancer still remains to be diagnosed in the relatively late stage, and that's the main problem has remained in head and neck cancer. The early head and neck cancer are curable by surgery alone. Next slide. However, when it comes to the late stage, the outcome remains very poor. And here you can see that the overall survival and the stage at the diagnosis by the site. And you can see that overall survival is the best in the lip as compared to the hypopharynx, where it's the lowest overall survival. Next slide. So once we realize this, we know that what are the changes that have occurred in over a period of time in the management of head and neck cancer. When we entered into the oncology, that's about 75 or so in India, it was very clear that there was nothing with us. The only treatment at that stage was surgical treatment, and that was the only thing which was there, and maybe also the radiotherapy, and that too the old type of the radiotherapy. So what we have seen now is a tremendous improvement in both these approaches. Surgery has changed remarkably. I remember we used to see the patient of head and neck cancer, and they used to undergo commando, and it used to take time and months together to recover, and many of them used to have a recurrence before the recovery. So that was the situation. Today, even surgical technology has improved remarkably. Today, patient, after the commando operation, patient walks out of the hospital after 5 to 7 days. And that's a remarkable change that we are seeing today. In terms of the radiotherapy also, in olden days, the radiotherapy was very crude. The whole skin used to become black and almost necrosed, and the results used to be very bad. And that's why many people, even today, remembering those patients, still they are afraid of the radiotherapy. It's an old memory which many people have even today. But that also, the radiotherapy, the modern technology, the precision technology, the whole approach in the radiotherapy has changed so that it has become more effective and at the same time less toxic. So I think all these things are happening in the head and neck cancer, both with respect to the surgery and radiotherapy. However, you can see that we have changed in the third modality of the treatment also. Those days we had chemotherapy. But what was the chemotherapy those days? Was simple drugs, like we had the 5-FU, 5-fluorouracil, we had a methotrexate. These are the two drugs which were known to be effective in head and neck cancer. And we used to give them to the patients. They will respond for some time, but surely they will come back with a progressive disease. So there was nothing very impressive response with the early days of chemotherapy. And then we started getting the better and better drugs. And among those better drugs, first one was the really platinum compound. Cisplatin, carboplatin had a major impact in overall outcome, so that ultimately the most acceptable protocol was cisplatin and 5-fluorouracil. That was a treatment which remained there for almost 20 years. And even today, many people use the cisplatin and 5-fluorouracil, which was a standard treatment. Of course, in those days, the same IFU and cisplatin used to give lot of trouble to the patient in the absence of effective anti-vomiting drugs. Now that today we have very good anti-emetic drugs, the whole protocol has become very acceptable to almost everybody. So you see, you can see the change which happened with the introduction of the newer and newer drugs. And subsequently, the next slide please, the other drugs also came up. Now here you can just see that what happened in terms of the treatment. That in the early stage, today, even today, the surgery remains the main pillar of the treatment, and in some patients, of course, the radiotherapy also. So for the early stage disease, these two modalities of the treatment can produce equal results. However, as it goes further, locally advanced disease, we need the combination, and that's where came up with the radiotherapy with the concurrent chemotherapy, and subsequently further chemotherapy alone, particularly in the recurrent and metastatic setup. And lastly, of course, the patients had refractory disease, and then the palliative treatment was introduced. So you could see that the drugs did have the effect right from the locally advanced disease to the refractory stages. Next slide. And here we can summarize that what was the development in terms of multimodal therapy for the head and neck cancer. We started with a single modality treatment, either only the surgery was done, or only the radiotherapy was given, or only the chemotherapy was given. And then later on, with the newer development, newer understanding of the biology of the disease, as well as about the radiology technology, we went into the pre-operative radiotherapy. And also, of course, the post-operative radiotherapy was also soon recognized. We also changed the approaches in use of drug therapy, that we started using induction chemotherapy with the hope that the tumor will become small and the surgeon will be able to resect the disease adequately and easily, and that really achieved some result. Then came the neoadjuvant therapy, particularly for the organ preservation, and I think the major progress that occurred was associated with the organ preservation, where the surgery became less and less, and other therapies became the major dominant therapy. And lastly, which is now widely accepted, is the concurrent chemoradiotherapy, where the combination of the radiotherapy with low dose chemotherapy has become a standard treatment in many conditions. Next slide. So looking at this, the lot of chemotherapy based regimen were introduced, basically after observing that each of these drugs which were available to us had some effect, nothing major, nothing dramatic, but it was 10 to 20, 30% effect. So individually, all these drugs did not have a real major impact. However, next slide, when we put these drugs, next slide, together in combination, we did achieve something better. And you can see that from 1960s and 70 onwards, we started using combination to achieve the better results. And some of the most of these combinations at the basic of cisplatin and 5-FU, and the other drugs like bleomycin was initially added, and later on taxane, either docetaxel or paclitaxel, were introduced, and that's how the whole thing became very important. And lastly, also we started recognizing some targets on the cell surface. Just now you heard that how these targets on the cell surface ultimately go through the transduction pathway and stimulate the nucleus, DNA. And if we block some of these surface molecules, that stimulation of the transduction pathway can be inhibited, and ultimately the nucleus will not undergo proliferation. And that's where the targeted therapy came up, particularly in the head and neck region. After looking at the data that epidermal growth factor receptor was prominently displayed in almost 80% of head and neck cancer. Next slide. And that's where the targeted therapy was also included, both along with the radiotherapy or along with the chemotherapy. Here we can just see some of the data that how chemotherapy had the effect, that patients were randomized to receive either platinum and 5-FU or taxane with platinum and 5-FU, and then went on to receive evaluation and ultimately the concurrent chemoradiotherapy and maybe surgery. Next slide. And one could see clearly, next slide, the difference. And here you can see that the survival as well as previous slide, please. Yes, survival as well as the progression-free survival was showed the improvement with the addition of the taxane. So I think that's where the TPF regime became a very standardized regime somewhere in 1990 or so, and we all of us started using this protocol. And again, I can tell you that in those days when we were using TPF, we used to be very much afraid of this regime, not because of anything else, but because of the fact that they will produce nausea, vomiting, and it was very difficult to control in those days till the introduction of the ondansetron and then subsequently so many other antiemetic therapy. So today TPF is commonly used everywhere, even in the small villages. People can use the TPF very safely by following the standard protocol. Next slide. So you can see that how over a period of time we went on improving the results. In the intergroup 0099 trial, the radiotherapy alone or radiotherapy with cisplatin was used. Next slide. One can again see the difference, but you can see the response rate. Response rate was almost double when you use the radiotherapy along with the chemotherapy in locally advanced head and neck cancer. Next slide. So in the meta-analysis of the chemotherapy in head and neck cancer, also ultimately we had to use the chemotherapy at different phases in the adjuvant or neoadjuvant or concomitant. There were so many trials. You can see what a number of trials were done, and absolute benefit in terms of the 5 years was seen in some of these trials, where you can see 1 out of 8 trials showed the absolute benefit. Next slide. So over a period of time we went on improving all these things. Again here the randomization between the cisplatin and the 5-fluorouracil with and without taxane clearly showed the superiority in terms of the response as well as survival in head and neck cancer. Next slide, with the addition of taxane. So everywhere, whether it was URTC and RTOG, the eligibility criteria were different, but ultimately it did have the effect. Next slide. And shown the improvement in survival. You can see in both the groups, whether it was URTC criteria or whether it's a RTGO criteria, there was a reduction in the risk of death by introducing the combined treatment. So I think all these things really had a major impact in the management of the head and neck cancer. And today we know that concurrent chemoradiotherapy has become standard even after the surgery. Next slide are the people who have a high risk of relapse. You can see over here a randomized trial where the surgery was followed by chemoradiotherapy, and they were randomized to receive the radiotherapy with cisplatin, radiotherapy, docetaxel, and radiotherapy with the cetuximab and docetaxel. Next slide. And all this randomization did show the better responses. So radiotherapy versus the radiotherapy plus cetuximab. Next slide. One can clearly see the difference in between these conditions. Then came this targeted therapy, the so-called cetuximab, and this was again you can see over here that how the EGFR was recognized on the tumor tissue, and you can see that in the head and neck cancer, 90 to 100% of them have overexpression of EGFR. Next slide, and that's where it was recognized to be a target. And here you can see that not only the cetuximab, when it is added to the radiotherapy, it showed the response, but it also showed the response when the cetuximab was added to the chemotherapy as well. Median survival did improve from 7.4 to 10.1. And I think those who have used this targeted therapy will clearly see the difference. Early on, as soon as you start the treatment, you can see the difference. If you have not used the cetuximab and if you have used the cetuximab. Next slide. So, other targeted therapy like bevacizumab also had a marginal benefit, but it was from 11 to 12.6 months in terms of producing the more deep response with chemotherapy. Next slide. So I think we learned a lot from all these things, but ultimately still the prognosis remains poor in metastatic, recurrent and resistant disease, and that's where the knowledge of the checkpoint inhibitor came in hand. Next slide. And all of us started using some of this immunotherapy, checkpoint inhibitors, and you can see that it was the evolution of the treatment for recurrent and metastatic head and neck squamous cell carcinoma, and the rationale was for targeting the immune exhaustion. An early phase result did show the benefit, and there were a lot of ongoing trials. Next slide. And this has been now used, and all of us, those who have used this, next slide, immunotherapy in head and neck cancer, one can definitely clearly see some of these patients doing well. Here you can see that those patients who received the nivolumab versus those who did not, there was a benefit by in median overall survival by 2.5 months, and again the median survival was also better. So see at 12 months 34% versus 19%, and at 18 months 21% versus 8%. So I think obviously the impact of the immunotherapy was noticeable. Next slide. And the other checkpoint inhibitor like pembrolizumab, also next slide, when compared with the standard care of the treatment, also showed the reduction in the risk of events, and therefore the patient's median survival became better. So I think next slide was very clear that the immunotherapy is going to stay here. And again, with respect to the expression of PD-L1, those who had more than 50% TPS score did show further improvement as compared to without immunotherapy. So 25% versus 46%, almost doubling the. While those who had the score of equal to 1 or little more than 1 did also show again the response, better response, but not to the extent when the TPS score was more than 50%. Next slide. Next slide. So I think there are many other sort of trials where the overall survival for the pembrolizumab plus chemotherapy versus the chemotherapy, and again you can see that there's a improvement. Next slide. So I think the point has reached now that we are now going to use all this treatment in an integrated fashion, that we'll combine different modalities of the treatment. We'll also combine the different types of the chemotherapy. We will also combine different types of the modality either before or concurrent or afterwards, ultimately to improve the results. And also we will use them when they become resistant to the standard treatment. And that's where immunotherapy has come to stay and will stay in the as a major treatment in the management of head and neck cancer. Thank you very much.
Thank you, sir. In half an hour, you explain whole journey of radiotherapy, oncology from beginning to now. And same time, you have not explained only chemotherapy and immunotherapy, you also give respect to surgical and radiation oncology. Thank you, sir. From as a radiation oncology, I will by heart to you. Now, any questions?
So Dr. Amish Vora has one question.
Can you unmute Dr. Amish, please?
Okay, Miss. Okay, Miss.
Hello, am I audible?
Yes, yes.
Oh, yes.
Sir, as always, there's always a revision of oncology whenever you speak. Thank you for that, sir. I just wanted to ask you, sir, in your clinical practice, I'm not talking of guidelines. I'm talking of, your experience is far superior to any other guidelines. Which patients of head and neck cancer you practice neoadjuvant chemotherapy followed by surgery and not followed by CTRT, followed by surgery? And what is your long-term experience of long-term survival, sir, in a day-to-day clinical practice?
Yeah. See, I use neoadjuvant chemotherapy quite effectively and in a sort of a very manner that you could get good responses. And I strongly believe in the neoadjuvant chemotherapy, particularly for the tumors. Of course, it's selective. Selective how? If the tumor is big tumor, proliferating tumor, they will respond. They will come and tell you after one course, the whole thing is gone. They feel you have done a magic to them. While at the same time, if you have a very infiltrating tumor and there is no proliferation, they are deep infiltration, they are not going to respond to the chemotherapy at all. So you better avoid the chemotherapy for them and let them go for the surgery, because that's the best chance that they have. So I think it's not only the rate of proliferation, Ki61 and all those things that we measure, but it's how you look at it. And I think the look of the tumor is a very important factor on which you can really apply the treatment more successfully.
Okay, Miss, satisfied?
Yes, sir. Thank you, sir.
Any other question? We have time, 5, 6 minutes, 6, 7 minutes.
Since nobody else is there and I love to ask
You
questions,
can ask
I ask one more question?
Okay, you can ask question.
Okay.
Sir, about immunotherapy, again I talk of neoadjuvant. Do you have any personal experience of neoadjuvant immunotherapy, sir?
Not really. I have not.
Not really.
It's
And
still
in
very
metastatic settings, sir, again, like proliferative and this infiltrative, you said, any practical tips where immunotherapy works and where it doesn't work?
Yeah, I think there are definitely tumors who will give you better results as compared to this. One which is very important is a tumor which has been radiated and recurrence is there. They always do well with the immunotherapy. In contrast to the tumors which are recurrent, they have never received any radiotherapy, the response rate is definitely poor. I think this is a most important factor that you can observe. I mean, I don't have the statistics, but I can see that when I treat such cases, patient has received radiotherapy, you always see either the partial response and sometimes even complete response. While patient who has never received radiotherapy, it's impossible to see any response. So I think that is one factor which is just the observation. It has no statistical support.
Thank you,
Thank
sir.
you, sir.
As no other questions, so I hand over the organization with thanks to them holding the innovations in there, and that is useful for everybody. Thank you, Samantha, and I thank you very much.
Thank you, Ashish sir. Thank you for chairing the session. And now I'd like to hand over the stage to the next year's person, Dr. J.B. Sharma sir, who again needs no introduction. J.B. Sharma sir is the head of medical oncology at Action Biology. So, hand over to you, sir, to chair the next session.
Thank you, Sumant, and thank you, organizers, for inviting me for this very important webinar. Now, Dr. Advani has given a view of the treatment or journey of the treatment of head and neck cancer. And now we will learn about the newer modalities in the treatment, surgical treatment of head and neck cancer. So I invite Dr. Kanuj Malik, who is consultant surgical oncologist at Sarvodaya Faridabad Hospital. And Dr. Malik has done his MCS from Cancer Institute, Adyar. So Dr. Kanuj Malik, please take the charge.
Thank you for the introduction, sir. And can I share my screen, please?
Yeah, Kanuj, you're audible. Your screen. Have you started your screen share?
Yes.
Yeah, your screen has started sharing. Yeah.
Okay.
Yeah, your screen is visible. Thank you.
Thank you. Thank you for giving me the opportunity to speak about the newer modalities in head and neck cancer surgery. As Dr. Ani has already told, we are going leaps and bounds in newer technological innovations, newer innovations in the Department of Head and Neck Cancer. So I'll talk about the surgical innovations. Now, head and neck cancer is a fairly heterogeneous group, and the surgical approach has progressed in two opposite directions. At one side, in one direction, we are going in a less invasive, respectful procedure. And on the other end, we are going towards extremely extensive procedure with a lot new methods for reconstruction. So the newer innovations about which I'm going to talk about are sentinel node biopsy, robotic surgery in head and neck cancer, then intraoperative guided surgery, fluorescent guided and CT guided, stereolithic modeling, and finally the application of ERAS in head and neck surgery. Sentinel node biopsy, since its inception in 1992, everyone knows has become a standard of care for clinically node negative melanomas as well as breast malignancy. The principle remains the same, that the sentinel node is the first lymph node, the first echelon node where the direct lymphatic drainage from the tumor site goes and is most likely to harbor occult metastasis. So if it is negative, there is no need to perform a formal lymph node dissection. So the similar concept was used for oral squamous cell cancers. As you can see on your screen, these are the four major studies which have been done for sentinel lymph node biopsy in squamous cell cancers. The first one from US, second one from Europe. And if you see on the right side of the table, they have achieved an accuracy of, everyone has achieved an accuracy of around 95 to 99%. And the false negative rate is comparable to as seen in other malignancies, around 9%, which is generally seen in breast also and is a very acceptable false negative rate. So, but what are the challenges and caveats that we are facing while using this technology in head and neck cancers? First, it is a false negative rate. Uh, the problem arises since head and neck is a very small region, there is a shine through effect for especially for the floor of mouth tumors. That is, when you try to search for a sentinel node using a gamma camera and your primary tumor shines, so you're not able to identify it. And especially if the tumor is large, this also contributes to the shine through effect. And moreover, if the surgeon is not as experienced in this technology, this problem really arises. The second is uh, a lack of reliable real-time sentinel lymph node information. We have been using frozen section to find out whether the sentinel lymph node is positive or negative, but there is some concern with that because the sensitivity rates have been reported in some series to be less than 50%. And lastly, unlike breast, the pathway of lymphatic pathway of head and neck cancers has been seen to be variable for many of the nodal basins. So how are we raising the bar and how are we getting through these problems? Currently, there is a new injection that is a DTPA, or commonly known for the head and neck trials is the tilmanocept, which exhibits more rapid clearance from the injection site. So the shine through effect will be less, and specifically it has mannose binding receptors which are located on the nodal reticular endothelial cells. So it will stay at the nodal site and not move from that. Second, how about if we can get a guidance system as to precisely tell us anatomically where is the sentinel node? So for that, we are offering a SPECT CT. Now in this, there will be a surgically relevant topographical orientation and delineation of the sentinel lymph node along with the entire adjacent anatomy. So this will help the surgeon to find out exactly where is the node. Lastly, there is a lot of research going on in this. Now, there can be a rapid intraoperative tumor identification of sentinel lymph node via molecular methodology. Along with that, if the sentinel lymph node can be identified using indocyanine green dye or infrared dye, there is research going on for that. And lastly, one of the things which I would like to highlight is combining of PET with sentinel lymph node identification. So what you can have is, now it is very difficult to achieve a real-time PET because we cannot shift the patient intraoperatively to the PET room. So the research is going on to have an intraoperative real-time PET to identify the sentinel node. The next innovation, well, is robotic surgery. Robotic surgery has come a long way, starting from 2000 when it was first approved for laparoscopic surgery, the Da Vinci system. After that, in 2009, there was FDA approval for TORS, and that is a transoral robotic surgery. And finally, now there is FDA approval for the flex robotic system for TORS. So it was first approved for T1 and T2 malignancies and benign lesions in 2009, and currently it is used for thyroidectomies, neck dissections, skull-based surgeries, and provides an excellent access to parapharyngeal space masses also. This is a photograph of the Da Vinci system being used for TORS. So what are our results with TORS? Well, this is one of the recent meta-analysis published in British Journal, which showed a comparison between TORS and open surgeries. And the results of this were that when compared to with respect to oncological outcomes, there was actually no difference in status of margin, recurrence, or survival rates in both of them. The quality of life related outcomes showed that the Since this study included most of the oropharyngeal tumors, so the assessment of impairment of swallowing was done by the need for nasogastric tubes, and which was found to be significantly lower in the TORS group. Lastly, the surgery-associated measures. There was decreased blood loss, hospital stay, and requirement of intraoperative tracheostomy in the TORS group. But what are the problems still with robotic surgery? One of the major problems is the loss of hepatic feedback and a high cost. Now, how we are overcoming that? What is the novel innovation in that? So the next level of robotic surgery is the Med Robotic Flex system. Now, this uses a robotic monocular camera, which allows the surgeon to manually control two wristed arms carrying surgical instruments, which is mounted alongside with the camera. Now, in the second photograph, you can see that the surgeon has gone beyond the vocal cords and still is able to visualize the subglottic region very clearly. And the camera has gone along with the two robotic instruments. So this is a next level of innovation. So how is the Flex robotic system better than the Da Vinci surgical system? It has a mobile camera, the haptic feedback is there, and it allows micro instruments for laryngeal surgery. The other innovation which is going to come in a big way is the Da Vinci single port system, or the SP system, which has a flexible binocular stereo endoscope that allows the instruments and the camera to pass through only 2.5 centimeter instrument port. The next innovation which I'm going to talk about is intraoperative guided surgery. Well, currently, as a surgeon, we are relying on our vision and palpation to assess the margins during resection. And before proceeding to reconstruction, we always like to confirm our margins by a frozen analysis. But how about there be a system that we can intraoperatively confirm our margins, or which can tell us from where to cut, how much to cut? So for that, we have one of the methods is optical imaging. Now, it has the potential to minimize positive margin rates and identify areas that are likely to be positive based on fluorescent imaging. Four fluorophores have been approved for general cancer imaging: ICG, ALA, fluorescein isothiocyanate, and methylene blue. Now, this is the general workflow of a fluorescence-guided surgery. The study drug is infused prior to the surgery, and then there is an in situ fluorescence imaging to tell us, as you can see, the red is the hot spot and the blue is supposedly the non-tumorous area. So it will tell us where to cut. Then you can always take a ex vivo specimen margin evaluation to find out whether the margin is adequate. And finally, for the histopathology, it can also be very, very valuable. Now, this fluorescence guiding can help you at 3 stages. First, the intraop, as I've already shown. Second is to find out the sentinel margin. Now, the sentinel margin is the one which is most likely to be positive. So once the resection has been done and you know the most likely margin is the deep margin, you can always take fluorescence image of the specimen. And as you can see, you can find out which area is actually most likely to be positive when taken for frozen. And to confirm that, you can take frozen from only this area and find out on histopathology what is the margin you are taking. Lastly, you can always take a ex vivo picture and guide the histopathologist from where to take the exact cut section to find out to tell the final report. As far as clinical application of this modality, it is still in its what we call embryological stage. The first in-human studies have been conducted in 2015 only, and to find out intraoperative and pathological tumor assessment with escalated doses of cetuximab iridium dye. And other studies have been done for head and neck squamous cell carcinoma, all in preclinical stages, but the results are very positive, and most likely more studies will be done with this regard. The other method of finding out the intraoperative margins can be a CT guidance. An intraoperative CT guidance system, that is a real-time correlation of the operative field with the preoperative data set, to find out where exactly we need to cut. Now, a demonstration of this system for maxillary sinus neoplasm was done by Homa et al. From Japan, in which they did this use this technique to perform surgery on 5 patients.
Dr. Kanuj,
Sorry.
we have 1 more minute.
Sure, sir. Now, as you can see, the system, there is a placement of this stealth station. And with the system guidance, you can always find out where to cut. The important findings are the system required only 10 minutes for setup and the accuracy was 76 mm. So this can be used definitely for revision surgical procedures and patients with extensive disease. Stereolithic modeling for reconstruction, it's simple to as done for other injuries, other modalities. You plan for high resolution CT scans, and after that, you make models, and based on these models, you perform your bony cuts intraoperatively so that, as you can see in this photograph, there is a perfect orthognathic relationship of the mandibular bone. Lastly, I would like to talk about ERAS in head and neck cancer surgery. ERAS has been extensively used in GI, colorectal, and thoracic. The basic tenets of ERAS remain the same: patient preoperative education, nutrition, glucose loading. But as far as head and neck is concerned, I would just like to highlight that there is an important role of topical antimicrobial decolonization using chlorhexidine rinses. Intraoperatively, we can use vasoconstrictors as they have not been shown to have any effect on flap. And lastly, for the postoperative intervention, there's a shift towards avoidance of routine tracheostomies. So I just want to tell that there's a lot going on in the field of head and neck surgery, and we are just waiting for long-term results to incorporate these findings in our routine clinical practice. Thank you.
Well, thank you, Dr. Kanuj, for apprising us about the newer modalities in the treatment of head and neck cancer, including the robotics. I invite Dr. Sawant sir for his expert comments.
Sir, Dr. JB sir, Dr. Sawant couldn't join us due to a family tragedy. So I'll request you to take the expert comments.
Okay. So, thank you very much, Dr. Kanuj, for these newer modalities like robotic surgery, intraoperative procedures, FNAC, and dye testing. I think this will be very great help for our patients who require specialized treatments in the head and neck cancer surgery. So, if there are any questions, we can take 1 or 2 questions. Is there any question in the chat box? Okay. So I think we can move onwards. We can move on panel discussions, which will be conducted by Dr. Amish Vora, and this panel discussion will be on PARP inhibitors and beyond in ovarian cancer. So the PARP inhibitors are generally recommended in ovarian cancers who are particularly BRCA1 and BRCA2 positive tumors, and the newer data says that it can be included in the first line treatment with along with cisplatin. So what is the new and what are the discussions? I hand over to Dr. Amish Vora.
Thank you, sir. Should I invite all panelists, or would moderator
Yes, you can invite all the panelists.
Or okay, the names which I have been given are Dr. Amit Verma, Dr. Kunal, Dr. Kripa Shankar, Dr. TVS Tilak, Dr. Kanuj Malik, Dr. Vikas Talreja, Dr. Vibhor Sharma, and Dr. Ranjit Sahu. Do we have all the panelists with us?
Ravindra, can you check who all are there? I think Dr. Vikas Talreja is there. Dr. Kanuj is there.
So Dr. Tilak is not there.
Rest everyone is there?
Okay.
Rest are there. Yes, sir.
Rest all are there. Okay, perfect.
That
I
is
can see
very
Dr. Amit
impressive.
also, Dr. Vibhor, Dr. Kunal, Dr. Kanuj, I can see them. Okay. Can I have my first slide, please?
Sure, sir.
Yeah. Thank you so much, Sumant, for inviting me for this amazing. So you better go fast.
Sir, it's always a pleasure to have you.
We are going to. So we are going to take 3 minutes, try to reach to some consensus about inhibitors in ovarian cancer. Let's see. Please remind me of my time when. So I love Dr. Kripa Shankar defining studies in various panels. So can I have Dr. Kripa Shankar to identify this study and comment on this? Dr. Kripa? Do we have Dr. Kripa Shankar? Okay. Dr. Ranjit? Sumant, do we have these panelists? Kripa
Hello.
Shankar, there
Kripa
I
is
see.
here.
Yes,
Yeah,
Kripa.
hi sir. Hi sir. Sorry, I wasn't
Hi,
able to
Kripa.
unmute myself.
No issues.
Sorry about that, sir. So I mean, I
So
think
you-
this. Yeah, we're talking about probably the solo one study here, and I mean, like the hazard ratio here was very impressive with a hazard ratio from 0.3. We're talking about a 70% relative risk reduction here. So I think this is the solo one study which actually led to the approval of olaparib in somebody with germline BRCA mutation in the first line as maintenance. So I think this is the solo one study.
True. Krupa, how can you ever be wrong? So let's move to the next slide. I want people to remember this slide because as Dr. Krupa Shankar said, this was unbelievable. When it was the first time, 2017, when the data was published and presented, hazard ratio of 0.3. And now in lung cancer, in ADURA trial, we see hazard ratio of 0.15. So we are reaching an era where we are seeing more and more from 0.86 to 0.3 and 0.15. Okay, my question to Dr. Amit Verma, and maybe then Dr. Kunal can take it. But before I ask this question to Dr. Amit, Dr. Vikas, do we have Dr. Vikas Talreja?
Yes,
Vikas,
sir, I'm there.
Can you answer the question? In clinic, you have money only for one BRCA testing. You do tumor or you do germline?
I know, sir, this question comes with a very catch, but yes, I would start with a germline testing and then do the tumor testing because.
So let's Vikas. Your point. Let's hold on there. I'll come back to you, Dr. Ranjit. Would you follow the same? Do we have Dr. Ranjit with us? I don't think so. I don't see.
So Dr.
him.
Ranjit is not there. He couldn't join.
Okay, perfect. No problem. No problem. Vibhor, I saw you.
Yes, sir.
Vibhor, would you do the same in your practice?
Yes, sir. I prefer to do the same. Germline first
Germline
and then
first, followed by somatic. Okay. Dr. Amit.
Yes. So
Dr. Amit also would do the same. Dr. Kunal?
Yes, sir. I would recommend the same.
I was very, very surprised. I couldn't download the slides, but there are two trials. There are concordance between germline and somatic BRCA mutation. And it is a very crystal clear that the tumor BRCA mutation has 100% specificity. So there are September 2019 and January 2020. One is ESCO post and one is in Lancet or one more article. If your tumor BRCA is negative, your germline BRCA would be negative. Amit, I want your opinion because in clinic, it is extremely important. Till yesterday, I have been practicing what you have taught me, Amit. First germline, followed by tumor. But the concordance between the two says the opposite.
So the catch here is, if the tumor is positive, definitely the germline will be positive. If the tumor is negative, the germline may be positive. There's a situation where we call as a the BRCA deletion and duplication, which is not easily picked up by the next generation sequencing, which is up to 10% of the cases. So you may miss a 10% of the germline BRCA mutations if you just rely on the NGS per se. And the comprehensiveness of the germline vis-a-vis the comprehensiveness of the somatic analysis of the BRCA gene is quite different. So BRCA is a long gene, so the comprehensiveness is far better for a germline. So it is.
Krupa Shankar, in your clinical practice, Krupa Shankar, in your clinical practice, when you know this statement is correct, that if the tumor BRCA is positive, the germline BRCA would be positive, what would you do by tomorrow? Would you start with tumor BRCA, and if the tumor BRCA is negative, then you go forward, and if the tumor BRCA is positive, you would stop thinking of all other tests? Krupa Shankar?
Yes, sir. So the way I would look at it is slightly different, sir, because I know, like Astra has rolled out this panel where we do the T-BRCA or the tumor BRCA. Tumor testing is available as well. So that picks up both the germline and the somatic. The only problem is I wouldn't know whether it's a germline or a somatic mutation if I happen to pick it up on the tumor BRCA. So if I do pick up a tumor BRCA mutation,
What difference does it make for the patient? I'm not talking of genetic counseling and family. What difference does it make in terms of treatment of patient?
so it may not actually make much of a difference as far as treatment decisions are concerned, sir. But again, I would like to point out that in the SOLO-1 study, only 2 patients had a somatic BRCA. All the others, rest of the patients had only a germline BRCA. And even if you look at the NCCN recommendation, those who have a germline BRCA have a category 1 recommendation for maintenance olaparib. For somatic, it's only a category 2A. So I think
I completely agree, Krupa Shankar. As I said, I have been following that till yesterday. Okay. ASCO guideline says exactly what you and Dr. Amit Verma is saying. But my point is, if the true specificity is 100%, why do we need to do in a so resources limited or when PARP inhibitor treatment choices there? Dr. Sumant, can I take you quickly? Do you agree or do you not agree? Sumant, you are the organizer and practicing.
Sir.
Ha, Sumant.
Sir,
Between
till now
tumor
I'm
and
also
germline sequence.
Sir, till now I'm only practicing germline first. So.
Okay. Would you change that given the fact that if the tumor is positive, germline?
So want to change because I think recently I was also part of that group only where we had discussed the BRCA. I think Dr. J.B. Sharma was with us where we had discussed this BRCA sequencing data. It was a symposium.
So Amish,
this
sir, can I just make a quick point, sir?
Yeah,
so,
Krupa, please. Krupa, what you were talking now in SOLO-1, please remember there the concordance study was not done during publication of data. Till that time also people were doing germline, and if germline was negative, they were doing tumor, where 2 to 5% of tumor will additionally pick up BRCA.
Sir, very true. The tumor data, the tumor germline, tumor testing data is now very strong. In fact, the 2019-20 data is very strong. And it should be practiced.
Resource limited, and also why I am saying this, I am coming to next question, and that question first Vibhor, Dr. Kanuj Malik has not spoken. Dr. Kanuj, you are a surgical oncologist, right?
Correct, sir.
Right. So Dr. Kanuj has operated and given a tissue sample. Dr. Kanuj, I'll come back to you. But before that, I see again Krupa on my field and Vikas Talrej. I want both of them to comment on this. If tumor BRCA is sufficient enough, would you do tumor BRCA and HRD together, or would you wait for HRD later on in a sequence?
So
Krupa first, followed by Vikas.
Sure, sir. So again, I think we need to take a look at the perspective and put it in terms of numbers. So when you talk about germline, you're talking about 10 to 15% having a germline BRCA mutation, and about 8 to 10% can have a somatic BRCA mutation, and then again another 20 to 25% can have HRD as well.
45 to 49% HRD plus BRCA. Yeah.
Exactly, sir. So total numbers around 45 to 50% will have all of these three put together. So when you actually check for a HRD, you're actually looking at the BRCA1 and 2 as well. And then you're looking at the genomic instability as well. In addition to that, you're looking at the genomic instability score as well. So if somebody can afford to do a HRD testing, that would be like the gold standard to go with, because would you would get all the information.
If somebody can afford, would you do upfront?
Definitely. Definitely, sir.
Okay. Vikas, do you differ in your question answer?
Agree, absolutely agree. If affordability is not in question, HRD upfront. If affordability is a question, germline to be upfront.
So Amit,
Yes.
I always take your final word in my clinical practice, and I'll continue to do so. But for this panel, I want to challenge you. If a patient is affording straight away HRD, which will include BRCA1, BRCA2, a single test, isn't it sufficient in 2020?
The answer is
If
yes.
patient is affording.
Yeah, the answer is yes. You just go straight away with HRD. Everything is all inclusive.
Right. So I say that this can be a practice changing statement from Amit. And I think 2020, there are a lot of literature which are coming. Please, any of medical oncologist or surgical oncologist, if they are contradicting with me, tell me. But Dr. Sumant, our consensus today is if patient is affording, if tissue is available, HRD straight away should be sufficient for
True,
us
sir.
to move forward.
True, sir.
Sumant, you disagree?
No, sir, I agree with you.
You agree with me? Okay. Somebody said no or yes. Okay, I'll take that as yes and move forward. Dr. Kunal.
Yes, sir.
I understand what I read is there are 3 different ways of doing HRD. Can you elucidate and help us understand which one should we offer our patients if finances is not an issue?
So, sir, I mean, mainly what we do is the HRR and the HRD, right? I mean, HRR is basically analyzing the different types of genes, the other tumor suppressor genes which could be there, right? Along with BRCA1 and BRCA2. And HRD essentially is the genomic signature. So while HRD is something that we do on next-gen sequencing, HRR is something that could be done on a PCR-based test. So again, HRR is less expensive, while HRD becomes much more expensive. So it all comes down to basically the costing of the patient. So these two are the main, modalities in which we test. The genes remain the same. The RADs, 51C, 51D, PAL-B2, BLIPs, along with the BRCA1, BRCA2. So these are the two main modalities that we use.
Amit, if finances is not an issue, which is the best way of looking at HRD?
So HRD, we have 3 methods. You can say 3 strategies to identify HRD. One is the germline mutation screening of genes related to HR repair. The other is the somatic mutation of the same genes screening for the HR repair. And the third is the evaluation of the genomic scar, which is normally offered by the Myriad Genetics, which talks about the genomic instability secondary to HRD, and which they give us in the form of a HRD score, which is calculated based on 3 parameters. One is the loss of heterozygosity, telomeric allelic imbalance, and the large scale transition. So these are the 3 important strategies, and the HRD score, what we get from the Myriad, also have a 3, you can say, calculated score out of that. So these are the things which one should know before ordering any test, what they are offering and what they are doing.
Thank you, Amit. Again, Krupa Shankar, if somebody comes with just 1 point mutation or expression of RAD51C, nothing else, no detailed HRD done, would you offer PARP inhibitor in absence of BRCA mutation?
So again, sir, just to clarify here, I think we're talking about HRR and HRD. One is the cause and the other is the effect. The HRR is the cause and HRD
You
is
are
the
right,
effect.
absolutely right.
Yeah, so HRR actually it refers to the DNA damage repair genes, and out of which PAL-B2, ATM, CHEK2, RAD51C, RAD51D, BRIP, BARD, all of these are part of the HRR pathway. So you're saying probably one of those genes are involved. We call that BRCA-ness or BRCA-like. So in that case, we have data in prostate cancer to actually where PARP inhibitors are approved based on HRR. But unfortunately, in ovarian cancer, we don't have the data to support that. To start using
If niraparib is available.
Yeah, even if niraparib, sir, I would generally not tend to use it because the magnitude of benefit was much higher in somebody who had a HRD, a score of more than 33 or more than 42 to be exact. So the magnitude of benefit is much more higher in somebody who's got a HRD as opposed to somebody who doesn't have a HRD. So for that matter, especially when I'm going to use such an expensive drug, I would look at the subset of patients who are likely to get the maximum benefit out of it. And for that matter, I would stick to the patients who have a BRCA or a HRD status.
So Amish,
I would not agree
yeah.
with you on this point,
Yeah.
Krupa, but I would let Amit speak because I am supposed
Yeah.
to ask questions and not give my opinion.
So I think if you hit a germline RAD51C in an ovarian cancer patient, which have a pathogenic or likely pathogenic alteration, then you have the answer that yes, this is a hereditary cancer what you're talking about. And if there's a strong
I
family history,
completely agree with
so
Amit.
then it is a surrogate of HRD. If you really want to be sure before giving a expensive drug like olaparib, niraparib, rucaparib, you better go with the somatic HRD testing and be sure and assure the patient about it. But to best of my understanding, you can speculate, yes, this patient may have a high HRD score, taken the maximum, you can say, chances. Yeah.
Exactly.
So I take from Amit and Krupa, ideal world and a practical world, and you segregate the difference between the two depending on the clinical case scenario. Can we move to the next slide? So I will now ask a clinical question again, Vibhor. In your practice, if patient can't afford olaparib at all, is there any point in doing BRCA1 ever?
Sir, am I audible?
Yes, Vibhor, go ahead.
So if we doing BRCA1, BRCA2 has got both prognostic implications as well as therapeutic implications as well as implications for genetic counseling. So depending on if even if patient can't afford olaparib, BRCA1, BRCA2 testing at least for genetic counseling point of view and offering risk reduction therapies to the family members if the patient turns out to be germline mutation positive. So it does make sense.
Okay, I was lost in between. My connection was lost. Am I audible now?
Yes, sir. So,
Okay. So Vibhor, you said that you would still go ahead and do BRCA1, BRCA2 in spite
yes,
of patient not able. And I completely agree with you, and we will not discuss this further in want of time. I think that is what the entire world in a logical sense would do. Third, next slide, please.
So just a one point, there is a phase 4 clinical trial that is open, which provides free olaparib for all those who are BRCA1 and BRCA2 positive. So if affordability is question, we can always refer to that clinical trial for olaparib.
Thank you so much. But because my point was, is olaparib the only reason of doing BRCA testing? That was my point, and that is answer is no. Can I have the next slide, please? Okay, now I would combine Solo 1 and Paola 1 for the want of time and would not go into the details because we have one more point to cover in next few minutes. Again, because Krupa Shankar, you always summarize studies so well, we keep coming back to you. Can you summarize Solo 1 and Paola 1 on a head-to-head and tell us so that I can ask next questions to Vibhor and Vikas?
I think the key difference is where the Solo 1 had only patients who had BRCA mutation were actually taken into the study. Whereas the Paula 1 actually had patients who had both, even who were even HRD negative as well as BRCA mutant as well. I think that's one key difference. And coming back to the data, I think the PFS advantage is almost to the tune of almost 3 years. Even though we talk about hazard ratio of 0.3, it was more or less almost 3 years difference in the PFS as far as the Solo 1 study is concerned. Whereas the Paolo 1 data, again, like I alluded to earlier, the magnitude of benefit was actually higher in patients who had a HRD or a BRCA mutation. It was the magnitude of benefit was much lesser in someone who did not have either. So I think that's that was my take.
So Krupa, what the study says is slightly in addition to what you have said. Vibhor or Vikas, you would want to add something in addition to what Dr. Krupa Shankar has already said? And can we go to the next slide meanwhile? Vibhor, do you want to add something?
sir. Anything in Paula 1, those patients who were it includes everyone, but those who were BRCA negative and HRD negative, in them the magnitude of benefit was very small. It was 16 months versus 18.9 months, although that has also been taken as statistically significant 0.7 hazard ratio. So that is something that we need to keep in mind.
Right. So what I am aware of Paola 1 and Solo 1, the difference is addition of bevacizumab. I think that is clinically number one point which we need to understand. And bevacizumab was added in neoadjuvant setting compared to maintenance. While in Solo 1, olaparib was started only after all the chemotherapy treatment was over. My question, and again, HRD status was included in Paola 1, while HRD status was not included in Solo 1. Because in clinic, if the patient is able to afford, would you give olaparib or would you add bevacizumab to olaparib?
I would, with the current clinical scenario and the data, olaparib alone right now, not addition of.
What is your reason for not adding bevacizumab? Don't talk about cost.
No,
All patients coming to you now, henceforth, are all going to be affording.
Yes, sir. But still, the magnitude of benefit as well as the criteria, I feel that I need some time, because bevacizumab, as we have seen over the previous experiences, the drug has not the
Can I have the
additional
next slide, please? While
the
Vikas speaks.
additional benefit of adding bevacizumab over and above olaparib, I have my serious apprehensions over it.
Excellent. Because next slide, please. I wanted to come to the forest plot chart of Paola 1. Next slide, please. Again, next slide, please. Next slide. Here, I'm coming to next slide, please. Yes. This is the slide. So this is a forest plot of Paola 1. And let's start from the bottom line. Okay. In BRCA positive or in HRD positive patients, if you see the hazard ratio of 0.31 and 0.33. And Krupa Shankar, you said, and I agree with you, that in Solo 1, the hazard ratio of 0.31. So is there any actual benefit of addition of bevacizumab? All the three medical oncologists, and I would like to ask Amit also his opinion, because Amit treats patients actively. Is there any benefit of addition of bevacizumab if you compare Solo and Paola, and if you compare the hazard ratio? We can start with Vibhor, then Krupa Shankar, and then Amit.
Sir,
Vibhor.
One more, in Paolo 1, if you look at the median duration of use of this olaparib, it was 17 months. But in Solo 1, patients were able to take it for 24 months, meaning thereby that there's something that addition of bevacizumab is doing. And in terms of reducing the duration of exposure that the patient is able to take. So if a patient is BRCA1 positive or HRD positive, I would be more comfortable to use olaparib alone, because I think that is the drug which will give the patient the maximum benefit. If adding bevacizumab in that particular study has reduced the duration of exposure of this agent, I think I would be more comfortable using olaparib alone.
But then you are saving 7 months of olaparib drug. Amit,
Yes.
sorry, Kripa Shankar, I'm just directly jumping to Amit. Amit, molecular wise or mechanism of action wise, do you believe that bevacizumab is better in platinum resistant subtype of disease?
So platinum resistant subtype and Avastin benefit, the answer is probably yes.
So do you think that if we add bevacizumab and olaparib, probably olaparib can take care of BRCA or BRCA-NES, and bevacizumab can take care of platinum resistance subtype?
So what I have understood in the ovarian cancer per se, if you find a BRCA mutation, then it is a driver mutation. It is present in all the tumor cells. You will hardly find cells or clones which are platinum resistant. So you may not have the rationale to add Avastin if that is the rationale. So I would alone love to give olaparib, and you will expect the same outcomes. That is my understanding of the subject.
Okay, so Sumant, the second consensus amongst the panel is that between olaparib and bev versus olaparib alone, I think all of us would prefer olaparib right now alone, because Solo 1 is a very clean catch, this thing. And we have a 5-year follow-up data of Solo 1 in ESMO 2020, and which still maintains the hazard ratio of 0.29 or 0.3, which is amazing. 56% of patients are without progression at 5 years. compared to 13% at 5 years. This is something unheard of. So I think no patient should be denied the benefit of PARP inhibitor upfront first line. Kunal, in your understanding, do you believe that PARP inhibitor from the tumor perspective would work better in first line compared to third line and fourth line? You are a histopathologist, so if you don't want to answer that, I understand.
Sir, I genuinely feel I'm not the right person to take that question, but I definitely have been reading a lot on the efficacy of PARP inhibitors, even in the I think even in the first line. I'm not exactly sure of the study which I was reading, but I don't know about the comparative analysis.
Understand. Amit, do you think that molecular mechanism perspective wise, sooner immunotherapy companies also are proposing all the trials sooner and sooner? So do you think that sooner is better or it doesn't matter as long as patient is platinum sensitive?
I think sooner is better because of a lot of immunomodulatory effect, and this can also help the inhibition of the resistance clones, one. And secondly, the tumor are more responsive to immunotherapy early on as compared to later on. So I assume that future studies will also reflect the same. Earlier, the better if you start immunotherapy.
Okay. Krupa Shankar, two questions to you. One is Solo 2 has overall survival data already, while Solo 1 do not have overall survival. So between two, first line and second line, would you choose overall survival data versus an excellent 5-year PFS data? And second question is Krupa Shankar followed by Vikas Talreja. In patient of platinum sensitive and BRCA positive, if you have to design a trial today, would you add low dose carboplatin as compared to olaparib, and do you think that carboplatin would be as good as olaparib? Krupa Shankar followed by Vikas.
So again, sir, I mean, like you rightly pointed out earlier as well, the difference between the Solo 1 and the Paula studies as well was in the adjuvant setting. People were getting randomized. If you had a CR, then you had to take only 2 years of olaparib. But if you had a partial response, you had to continue olaparib until progression. And
Amish, Dr. Tilak has joined.
Yes, Dr. Tilak, hi, how are you? Dr. Tilak doesn't like to answer to me.
Okay, sir, I'll just continue.
Yes, Krupa, sorry.
No problem, sir. So again, I mean, like if you, we have data from the Solo 2 study. Which
Hi, Dr. Amish. Sorry, I was unmuted.
No problem. Krupa, go ahead, and then we'll take Tilak head on.
Sure. Sure. So the Solo 2 data that you rightly pointed out has shown a 13-month improvement in overall survival. I think it was 51 versus 38 months, has shown an improvement in overall survival. But however, it has to be remembered that the drug needs to be continued until progression in that setting. Whereas if you're going to use it in the first line setting, you have a finite period, especially if you have somebody who's already gotten into a CR, you're only going to use the drug for 2 years. And the magnitude of benefit as far as the PFS is concerned, close to a 3-year improvement in PFS, is something which I'm very impressed with. So I would definitely look at using it in the first line setting if somebody's got a germline BRCA.
Completely agree. Krupa, do you believe that 15 to 16 patients in Solo 1 have not relapsed even after 6 years? Do you think they are cured? Would you call them cured?
I think we can call them operational cures, sir. Just like how you're saying CML. In CML, you're doing the stop strategy.
True,
I think probably we could talk about operational cure as a matter of fact for these patients. But
okay.
Interesting, sir. Interesting.
Yeah, so since Tilak has joined, let me ask my second question to Tilak. Tilak, if you have to design Solo 1 today, trial, or Solo 2 for that example, do you think that a patient who's platinum sensitive, and this idea was given to me by Dr. Sudeep Gupta, so you better answer correctly.
Oh my God.
If we design today in a platinum sensitive patient with BRCA positive, olaparib versus maintenance carboplatin, do you think you would see any difference between the two comparable arms?
So among the various maintenance strategies, carboplatin has also been tried earlier, and there is some.
Taxane has been tried maximum, Tilak.
Yeah, exactly.
I have argued this with Sudeep over 45 minutes. I couldn't win his argument.
So you mean to say olaparib versus carboplatin?
In a
In fact-
subset of population which is platinum sensitive and germline or somatic BRCA mutation positive. We are talking of subset. When the maintenance was planned, none of these subsets were present. Remember that.
There's definitely science behind it, because the moment the patient is BRCA positive, there is evidence of better effect of platinum as well as olaparib. Side effect profile excluding, I think it's a good science behind the whole thought process. I wouldn't say anything beyond that.
Okay, so Tilak, why I asked you that question, because you can plan that. Yes, Amit.
May I answer this?
Yes, yes, Amit.
Quite
please.
interesting concept behind this.
Yeah.
So there are two subsets of category: platinum sensitive and PARP inhibitor sensitive. You may see a lot of overlap in few clones that they may respond to both the things, but there may be two different clones. You may have a different responses. So ideal would be to combine olaparib and platinum as a maintenance. That would be the ideal case, but that would be the third arm if you want me to intervene and give a possible trial plan actually. So even in the therapeutic point of view, I also sometimes recommend to combine PARP and platinums, which increases the response rate in what we have seen actually. And there's a strong rationale behind it.
Amit, the whole idea of proposing this subset is, the cost difference between carboplatin and olaparib. And the science says that probably they both may be similar. Vibhor, next slide, please. And Dr. Vibhor, patients you would like to use in first line or second line? Olaparib.
So olaparib, I would like to use in first line.
Okay, so you have a patient who has relapsed after, say, 11 months of olaparib. A patient stage 3C, ovarian cancer, 3 cycles of NSCT, surgery, 3 cycles of adjuvant chemotherapy. Patient is in CR. You have started olaparib, germline BRCA positive, family counseling done. After 11 months, CA125 is 230, and patient has lymph nodes in the abdomen. What would you do? Would you re-challenge olaparib with some other addition, or would you change to niraparib if it is available, or rucaparib if it is available, or you would do something else?
Dr. Amish, we have 5 minutes left.
Okay, sir. But I am coming to my last point is post-PARP what? And then I am done with this panel.
Okay.
So this is a platinum sensitive relapse. What you 11 months post olaparib. So
would you call it an intermediate platinum sensitive, or would you call it as platinum sensitive?
Intermediate platinum sensitive, but it's like 11 months close to reaching almost 12 months. So certainly platinum based chemotherapy would be there. Now, as far as changing over to niraparib or veliparib is concerned, sir, I am not aware of any data which suggests that changing over from one PARP inhibitor to second PARP inhibitor would be of any would add to the benefit. I am not aware of any such.
Right. You are next slide, please. So there is a phase 2 trial where the re-challenge. Next slide, which tells us that there is some response, but you have to add VEGF inhibitor along with olaparib for it to have the recurrence, for it to have a response. Next slide, please. So, Dr. Tilak, my question to you is, we have just 5 minutes left and you have joined late. Immunotherapy in your clinical practice?
I have not used
use immunotherapy in ovarian cancer.
So I have not used so far, but the ovarian tumors with tumor infiltrating lymphocytes have been shown to have better response. Now, those patients who are probably BRCA mutant, it has been shown that probably they have more amount of new antigens which are present, and so immunotherapy may have a role. I have not used.
Have personal experience of
no,
it.
No, I've not.
Okay, Vikas, Vibhor, or Krupa Shankar, do you have any personal experience, or where would you recommend immunotherapy in your clinical practice? Meantime, can we keep changing slides, please? Next slide.
Yes, sir. Probably.
Yes, Vibhor. Sorry, Vibhor. Vibhor first, followed by Krupa Shankar.
I don't have any personal experience, but I would probably use it after exhausting multiple lines of therapy.
So Vibhor, let me
Sir, I
ask
have
you,
a
if the
question.
patient comes first line, sorry, 1 minute. If the patient
Yeah.
comes first line, Kunal later on, because we have
Yeah,
very
sir.
little time and this
Sure.
point is the last point. Vibhor, if the patient has MSI high, where would you use immunotherapy in ovarian cancer?
Not in the first line, sir. Not in the first line.
Okay. Krupa?
Sir, this
where
was
would
my
you use
question.
in MSI high. Okay.
Yeah. So I would definitely look at using it only in the platinum resistant setting. So long as the patient continues to remain platinum sensitive, I would still look at re-challenging platinum and along with that adding the second agent. But once the patient becomes platinum resistant, we run out of options. So there I would definitely look at using immunotherapy, especially if the patient is MSI high. And there is some data to actually combine PARP inhibitors plus immunotherapy in that setting as well, in somebody with platinum resistant disease. So I think
There are
that would be
3
the
large trials going on, and
Yes.
2022 would be the data readout. My question is, Amit.
Yes.
MSI high, where would you recommend adding immunotherapy? See, I'll tell you
So
the reason I'm asking this
yeah,
question.
yeah.
We all have, sorry Amit, we all have Krupa, Vikas, Vibhor, we all have patients of MSI high who are doing extremely well on immunotherapy right now. You know, and I don't want to miss out. So the carry home message, Amit, from you in MSI
So-
high ovarian cancer.
So MSI ovarian cancer immunotherapy is definitely an option. When to use it? If I get this information early on while I do my somatic analysis, I would recommend for a few initial cycles of olaparib and immunotherapy in the maintenance setting, followed by olaparib alone. You may get a very good control of the disease. That is my take on the subject. And if there is a recurrence, you still can re-challenge the patient with the with immunotherapy. There is no harm. So I would love to use it in the maintenance setting early on.
Right. Am I audible?
Yes, sir.
Yeah.
Yeah. So I think, this, to sum up, immunotherapy or MSI high, the first line setting definitely not recommended. There is not a single guideline in the world which says that MSI, like in colorectal cancer where we have first line approval, we do not have first line approval. More than 2 lines of therapy somewhere where MSI high sub cohort of pembrolizumab is there, so we can try using there. So I think 2 lines of treatment, by which Krupa also said that patient may be platinum resistance and you can try. I would not wait for platinum resistance. If 2 lines of treatment are done where we have looked at PARP inhibitors also, I would add immunotherapy in that patient, particularly patient. Any clinical experience, Vikas, you have or Krupa you have of immunotherapy plus chemotherapy in ovarian cancer? I have 3 patients. That's why I'm asking. And this would be my last question. We would stop panel after that. Vikas, do you have any personal experience of using?
Sir, around 30-40 patients we have of not immunotherapy on the third line when we have given pazopanib plus cyclophosphamide. So that's also a very good option. The median progression-free survival is around 8 months with upper limit of going up to even 18 months. So that's a good option for those probably not fitting into the subset of immunotherapy. And another point which I wanted to say about the low dose or probably an alternative dose of carboplatin maintenance versus vis-a-vis olaparib, I think the idea is amazing, but the idea since so far hasn't got implications because in breast also we have been struggling with, most of us would agree that the TNBC or the BRCA like subset would be benefiting with the addition of platinums, but the data keeps on conflicting. So I feel that since this data is mature and this has phenomenal results, I don't think so carboplatin would ever fit in so far now, sir.
Okay, Vikas, we will discuss about that later. And beyond PARP inhibitor, you have given one option of pazopanib and cyclophosphamide. I think all of us agree. In the era of immunotherapy, let us not forget the cheaper options and efficient options which are available. Krupa, you have any personal experience of immuno plus chemo?
So I've just used it in one patient of mine so far, sir, and my experience hasn't been that great. However, I'd like to highlight that this is one of my patients who actually went on and got enrolled into a clinical trial at MSKCC on this antibody drug conjugate against the folate receptor alpha, which is called mirvetuximab sorbitansine. So I think that patient is actually doing pretty well and still keeps in touch. So I mean, like, that's something which is another option as well, targeting the folate receptor alpha, the antibody drug conjugate, which is called mirvetuximab soravtansine. And we have phase 3 data called the forward study as well. So I think that's something which we could look at as well.
Excellent. So beyond PARP inhibitor, that is one. Amit, have you used immunotherapy in ovarian cancer?
Yes, the answer is I've recommended immunotherapy in ovarian cancer. And luckily, I came across PDL1 and PDL2 amplification at gene level. So I've recommended in that category and MSI high category as well. So regarding the use
Can I
of
have next slide, please, while Amit speaks? Amit, go ahead, please. Next.
Yeah. So regarding the use of immunotherapy and PARP inhibitor early on, I was just trying to push that thing because of the possibility of activation of your immune mechanism better actually. So as we are learning that the role of immunotherapy is moving from stage 4 to new adjuvant setting in various cancers, I also foresee the same for ovarian cancer. And BRCA mutant are the one which will be responding better actually.
Okay, excellent, Amit. But this December 2019 JAMA Oncology, if you see, these are the various patients, and the first few patients which have responded to immunotherapy plus bevacizumab, platinum sensitive are majority of them, but there are good platinum resistance also. There is no correlation between PD-L1 positive versus negative versus BRCA mutated wild type or not wild type. So I think there is a lot to learn in ovarian cancer. We have a lot of new options. At the same time, let's not forget old options, as Dr. Vikas said. Many of our ovarian cancer patients live for years and years. But yes, BRCA testing is here to stay. Olaparib is here to stay. Sooner the better. And immunotherapy, still we do not know where exactly the place in ovarian cancer. In terms of immunotherapy in combination with bevacizumab, we don't know. Again, we need more data. Bevacizumab plus olaparib probably is as good as olaparib. We need more data to incorporate 15 mg per kg of bevacizumab, which is extremely costly affair. With that, I conclude my panel and I thank all my panelists. Dr. JB Sharma has appeared on the screen, so I have to shut up now.
Okay, thank you, Dr. Amish, for very interactive and very interesting and very knowledgeable this panel discussion. Thank you very much, all the panelists. I now hand over the proceedings to Dr. Sumant. Sumant?
Thank you, sir. And I'm very thankful to everyone, all the faculty members, all the delegates who have joined us on this auspicious day of Dussehra today. And as usual, Dr. Amish Vora has brought a lot of hope to oncology today. And on a lovely panel discussion, he has made us all agree to a lot of consensus. Dr. Advani sir and all the speakers for teaching us a lot today. And I thank everyone who has joined in and logged into this webinar today. Happy Dussehra, everyone, and thank you. Hope we'll meet again on some other platform. Thank you, JB sir, for chairing these last sessions and keeping us on time and track. Thank you, everyone. Have a good night and happy Dussehra once again.
Thank you.
Dussehra. Thank you. Bye.
Everyone will have a count. I'm going to go like this.